everyone. The topic for today is, can epithelial mapping be a surrogate marker to predict refractive surgery outcomes? So in our routine refractive surgery practice, despite thorough pre-op workup and normal parameters, we still come across certain unhappy patients. Though 80% of the patients are happy, we do come across 15 to 20% patients who are unhappy post-surgery. They will complain of poor quality of vision, irritation, burning sensation, ocular surface discomfort, and glares and halos. So, it's not moving forward. Yeah, what could be the reason for these variable outcomes? So, the answer usually lies in the wound healing cascade post-surgery. And to understand this, we can look at the immunological response and the nerve regeneration. However, it is difficult to do so due to lack of time, equipment, and elaborate research models. However, this wound healing cascade after refractive surgery also results in epithelial remodeling, and this has been proven in various publications in the past. Various patterns of epithelial remodeling are seen after refractive surgery. However, there is a need to correlate this epithelial profile to the clinical outcomes after refractive surgery. We know that there is a vast literature supporting that the epithelium remodels as a consequence of the refractive surgery. However, in the presence of ocular surface inflammation, the remodeling is exaggerated, which can have implications on the postoperative outcomes. This brings us to our research objectives. First, to assess the pre and the post-operative epithelium status of patients undergoing refractive surgery, to identify if epithelium has an impact on the quality of vision, and to assess if the epithelial profile can serve as a surrogate marker to predict post-operative outcomes in refractive surgery. So this was a study. It was a prospective observational study in which there were 100 patients undergoing refractive surgery without any pre-existing ocular surface disease, and patients were myopes and refraction matched. Apart from the routine testing, they all underwent epithelial imaging on the MS-39. All underwent LASIK without any prior treatment. The optical zone flap depth was constant, and the same surgeon operated on all the patients. Epithelial imaging was repeated post-surgery, and the epithelial aberration data was also noted. We also looked at the subjective visual quality based on the VFQ25 questionnaire for all the patients. Coming to the results, 71 patients had a regular epithelium pre-surgery, which were considered group 1, and 29 had irregular epithelium pre-surgery, which was the group 2. Irregular epithelium was defined when the difference between the center and the peripheral epithelial thickness at the 6 mm zone was more than 7 microns. Coming to the results, we looked at the epithelial thickness post-operatively. So the group 1, which already had a regular epithelium pre-surgery, in them 91% of the patients had regular epithelium even after the surgery. Group 2 had only 18% had a regular epithelium post-surgery. 94 patients of group 1 had a VFQ25 score of less than 80, and 82% of group 2 patients had VFQ25 score of more than 120. That means they were unhappy with their quality of vision. When we looked at the aberration data, 85% patients in group 1 had a coma RMS of less than RMS difference of less than 0.5, whereas the 94.7 had epi-HOA RMS difference less than 0.5. In group 2, 62.6% had a coma RMS difference of more than 0.5. So to understand the wound healing, we delved further, and we also did a confocal microscopy pre-operatively for these patients. 91% of the group 1 had normal confocal findings, that is healthy nerves, but 86% of group 2 had either dendritic cells or microneuroma suggestive of an underlying ocular surface inflammation. So we actually looked at these three types of patients. The one with healthy nerves had a normal tear biomarker inflammatory levels, and the patients with immature dendritic cells and microneuromas had raised biomarker levels pre-operatively. Also, their epithelium in the patients who had healthy nerves had a regular epithelium, but those with immature dendritic cells and microneuromas had epithelial thickening and irregular epithelium suggestive of underlying ocular surface inflammation. When the surgery was done on these patients, the inflammation was exaggerated post-surgery, especially in patients with dendritic cells and microneuroma, and the epithelium was highly thickened and irregular. Also, it reflected in the biomarker levels post-operatively and the quality of vision. So thus to summarize, if the preoperative status was healthy, the patient was happy post-operatively, as opposed to the patients who had underlying ocular surface inflammation. This reiterates the fact that patient inflammation drives changes in the nerve cell density and dendrites, which results in diminished supply of neural factors to ocular surface, resulting in injury to the epithelium. Thus, the epithelium is indicative of the underlying neural health and biomarker status and can be a surrogate marker of the ocular surface health. These patients need treatment, pre-surgery treatment with immunomodulators and steroids and procedural treatment if required, which will bring down the pre-operative subclinical inflammation, improving the post-operative outcomes. Thus, our study basically talked about epithelium remodeling having an impact on quality of vision and the underlying ocular surface inflammation affecting the epithelium remodeling, which adversely has implications on the post-operative outcomes. Thank you.
So if there is a irregular epithelium preoperatively, you think of ocular surface inflammation in terms of
yes,
dry
so
eye.
that's what we're trying to say.
Now,
That
anything else we can think if there is a irregular epithelium preoperatively? One you said it is in terms
yeah,
of ocular
so
surface
it's an
inflammation,
irregular cornea with like irregular that can cause like it can be a masking effect in cases of thinner corneas. But those kind of patients were excluded from the study. We ensured that they didn't have any ectasia or any thin corneas.
Okay. What message you would like to give if there is a
So we want to say from this that we have correlated the epithelium with confocal and the tear biomarkers, which correlated very well. So if the epithelium is not just thick, it should be irregular also. If it is irregular, then it is better to just pre-treat the patients with steroids or immunomodulators and good lubrication at least for 4 weeks, and then take up the patient for surgery. So that even though, so because some patients are 20/20 but not happy with the quality of vision, which is very difficult to explain at times. So if the epithelium remodels regularly, there is going to be thickening, but at least if there is no irregularity, they will be happy.
So also it can be very early ectasia also. That is what we are.
Early ectasia,
So
yes, sir.
you have to be careful. Not only the
So actually in MS-13 we also can look at the stromal elevation. So that was not present. We ensured that that is not there in these patients.
So it was only epithelial irregularity.
Yes, ma'am.
So were these patients long-term contact lens users? Did you have a history of how long they'd been off their
yes.
contact lenses?
Yes, ma'am. So if you have a very chronic contact lens user, we ensure that the patients are off contact lens for 3 to 4 months, and we start them on lubricants, and then only we take them up for surgery. So that is something we follow.